Myra and Sarah, thank you for having us. We appreciate you pulling together this crowd. So we are going to talk a little bit about Black Maternal Health Week, which actually began a couple of years ago, really as a national movement to bring attention to Black maternal health. In particular, in New Jersey, this is something that we take quite seriously, working quite a bit on the Nurture NJ strategic plan launched by First Lady Tammy Murphy. But we're going to talk today a little bit about the intersection between Black maternal health and the COVID-19 pandemic. We think it's important to create some space to have discussions about this topic, because as I say to folks, people are still having babies. We had issues before the pandemic, and many of those issues have been exacerbated as a result of the pandemic. And then the other thing that I'll say is the news changes every day. Every day we're getting new information, additional information that may raise new questions. One of the things that came out this week was just the issues with the J&J vaccine and the need to pause on that vaccine. I got the J&J vaccine, so I keep waking up waiting to see what's going to happen to me. And so I have concerns, but Dr. Campbell assures me that I'm going to be okay. I see her smiling. She's giving me the 2 thumbs up. But I say that to say that I was happy to get it, and I was happy to get the one and done shot. But I know that other people had reservations. And so we have been working with communities that look like me, often to really improve their confidence in the vaccine. And so it's a bit of a setback because there were still some people who weren't there yet. And, as is human nature, when we get an opportunity to do something that we didn't really want to do, we don't do it. And so I think we have our work cut out for us in terms of making sure that the vulnerable populations really get the information that they need to make decisions for themselves. And so one of the things we do a lot of in ELC is really work to sort of bridge that divide. And so we do that by employing community health workers. We do that by creating health education materials. And we've even done that by having community-based site service testing venues, or hopefully in the future service vaccination venues. And so we have a lot of work to do, but we kicked off this series this week really because it's Black Maternal Health Week. So it has a maternal angle to what we're talking about. We have 3 presenters, I say. We have a doctor, Dr. Campbell is an OBGYN who is at University Hospital, but also at New Jersey Medical School, and also at the New Jersey Department of Health, where she works as the Executive Medical Director of the Maternal Care Quality Collaborative. Then we have Chi, who is a health data specialist with the New Jersey Department of Health, who will talk to us about data. So we have a doctor, we have data. And then we have one of my community partners, Marie Kinsella, who is a senior community health worker, to really talk to us about what's going on in the field, what's going on in the community. I will make a few remarks just to kind of set the stage, and then I apologize because I'll have to leave, but you should all sort of continue to discuss. But this is really designed to be a safe space. Come with your questions. This is the place where no question is insignificant. You have a doctor, a data person, a community person, Myra, Sarah, who have the ability to support you, to really ask questions to. If there's something you're not sure about or something that you think that you need or that you think your community needs, this is the place to talk about that. So I just want to thank you all for coming out. I think it's impressive, that we have over 40 people on this call who think it's important to come out and get some information. So I'll stop there and we can jump right into the slides. Okay, so I think I talked a little bit about this. Marie is a full spectrum doula. That's Marie Kinsella. So please tell us who you are in the chat box as well. That would be helpful. Thanks, Marie. We'll talk a little bit about Black maternal health before the pandemic. We'll certainly talk about how the pandemic has impacted this area. We'll talk about the vaccine, what you need to know, what is not true, and what we don't know. And then we hope to really talk a little bit about what is needed in the community. What are the social supports that people need from the perspective of a doula and also from the perspective of a community health worker. Next slide, please. Okay, April is Minority Health Month. So the entire month of April is Minority Health Month. And this week in particular, from the 11th until the 17th, is Black Maternal Health Week. And it really was a week that was designed to bring attention to the crisis we have in Black maternal health. It is something where there's activities that happen in several states and also activities that happen at the Capitol. I think Vice President Harris signed a proclamation yesterday declaring this week Black Maternal Health Week. Next slide, please. All over the news. This is unprecedented. I've been with the department for about 23 years. I've never seen this type of media national attention around the issues of maternal health and infant health, and particularly talking about the disparities. So this is new. When the presidential campaign was happening last year, they were actually asking candidates what they were going to do or what they would propose doing to address the Black maternal health crisis. So a lot of attention, a lot of energy, a lot of diverse partners, but also a lot of work to be done. Next slide, please. When we look at pregnancy-related deaths by race and ethnicity across the country, you can see from this graph, Native American and Alaskan Native and Black women are 2 to 3 more times likely to die from pregnancy-related causes than their white women. And these stats are even more stark in New Jersey, which we'll talk about in a minute. Every maternal death is a tragedy. Almost 700 women die as a result of pregnancy complications every year in the United States. And they say that up to 60% of these deaths are preventable, meaning they were deaths that didn't need to happen. And this is all pre-COVID. This is not talking about anything that is COVID related. This is sort of the state of affairs under normal conditions, even though this is not normal. Next slide, please. And the rates are increasing. They're not improving. They're actually getting worse in some ways. I think they say out of the 10 top industrialized nations, the United States of America is in 10th position on this issue. So we are not doing well amongst our counterparts either. And we're really drilling down to try to understand what exactly is driving this. Next slide, please. So pregnancy-related deaths are deaths that occur for up to a year after pregnancy. Many people think that it's a death that can only take place during childbirth, for instance. And you can see from this, that is not the case. You can see from this graphic that these deaths occur across a period of time. So some do occur during pregnancy. Some do occur up to 1 week afterwards or during childbirth, or very close to, and then some occur up to a year after a woman has given birth. And so we have a period of time that we should pay attention to where things can go wrong. Next slide, please. In terms of our Garden State on the left, we're 47th. We're ranked 47th in maternal health, so not a good ranking at all. And as I mentioned, 60% of these maternal deaths are preventable. This is the problem. It's all a problem, but this is where we see from the graph that Black women are up to 7 times more likely to die from pregnancy-related deaths than their white counterparts. This is alarming. And this is once you control for socioeconomic status as well. And so really an area that we have to pay attention to, and an area that from the graph, at least for the Black women, seems to be increasing. Next slide, please. This is where I will stop and turn the program over to Dr. Damali Campbell, who is also a member of the Maternal Mortality Review Committee, which is a committee that reviews maternal and tries to give us recommendations for us to move from data to action. So I will stop there. After Dr. Campbell, Chi from the Department of Health, the health data specialist, will present on the CDC and COVID pregnancy project to really give you a sense of what the numbers show in New Jersey in terms of pregnant women who are impacted or exposed to COVID, and the CDC project that we're involved in. And then after that, Marie Kinsella will speak to us about what's happening in your local community. So thank you, and thank you to the presenters in advance.
Thank you, Assistant Commissioner. I'll just say, not to make light of anyone who's gotten a Johnson & Johnson vaccine, because I know that there are a lot of concerns, but you know, let's just keep it in perspective. 7 million people have gotten a vaccine, and we're pausing, which is the right thing to do, right? We want to look and see and make sure that there's nothing to be more concerned about. So it's with, I think, an abundance of caution, 6 people with blood clots, but 7 million people got the vaccine. So I think, you know, we're doing the right thing by pausing and making sure that we're doing the right thing, but I'm assured that you're going to be just fine. So moving on to, you know, the topic of discussion for today, which is, you know, one of the things that I am a practicing obstetrician. And so like many of you, I'm on the ground. I'm seeing patients almost on a daily basis. And so, you know, they have a lot of questions, and we want to be able to give them the answers. And actually, sometimes that means we will have to say, I don't know, because we don't have all the answers. And sometimes that's okay too, because we want to be honest, we want to be transparent, because, you know, we're building relationships with people, and this is not a one conversation and done. So are pregnant women more likely to get COVID? And I think that depends. I'm, again, talking to women on a daily basis about this. Certainly, we know that there are more women in the workforce than in 1918 when we had the last pandemic. And so, you know, and when we think about what women are doing in the workforce, they're doing childcare. They're doing transportation, they're doing nursing, they're doing manufacturing, they're working in food service industries. And so all of these, you know, jobs and positions that many women and many women who look like me are working in, put them at risk for exposure because they're not jobs where they can work from home. Secondly, you know, the question is, are there risk factors, particularly in pregnancy, for more severe disease? And, you know, certainly we know that, you know, we'll show some information that we know about pregnancy, and we'll get some more information from Chi and the Pregnancy and COVID project. So fortunately, that is, pregnant women are not more likely to have severe disease, but if they get, most women do fine, but if they do get severe disease, we do know that they're more likely to be in the ICU. So next slide.
That's crazy.
Okay. And so what's the COVID-19 impact on pregnancy? Okay, so like I said, most women, fortunately, who get COVID during pregnancy, fortunately, most of the time, women are younger during pregnancy, and they do quite well with minimal complications. Again, we do know that because there is some increased risk associated with pregnancy compared to women who are not pregnant, that if women do get severe disease, that they can be, they are at risk for increased admissions to the ICU, increased risk for intubation and needing ventilatory support, and an increased rate of death. One other interesting thing that has been noted so far is that it appears that women who have gotten COVID-19 have an increased rate of preterm birth. And I'm sure that many of you doing this work in maternal child health already know that part of the reason for such a high infant death rate that we have has to do with babies being born prematurely. And so we don't need any additional help with preterm birth, because that is going to likely show us some increased rate with complications with our children living to be past the age of 1. Next slide. So this is some data from the CDC from January 2020 to January 2021 that just shows the breakout of women, what the age range looked like. And this was just data that was collected. This is by no means all inclusive of all women who got COVID, because not every place actually identified if women were pregnant at the time when they tested positive with COVID. But this is the information that we have. And so as expected, we see that most women are falling in that age range of 20 to 34, which is what we would expect, because that's when most people are pregnant. Next slide. So another question that comes up, are Black women more likely to get COVID? And so there's nothing inherent that African-American women are more likely to get COVID than anybody else, essentially based on race. But the question really links into what is the risk for women of color, what's their risk of exposure? And so we know, again, when we think about women who are in the workforce and the jobs that they have, are they at higher risk for exposure? So if we look in, for example, in the healthcare industry, which I know a little bit about, we see that a high percentage of persons of color who work in the healthcare industry are persons who have to physically come to work. They work in environmental services. They work in the nursing department as bedside nursing staff. They are not, they don't have the higher percentages in the C-suite where folks are able to work from home. The second factor has to do with risk factors for persons getting more severe disease. And so some of the major risk factors outside of age include diabetes, obesity, or what we would call elevated BMI, and hypertension. So those are all risk factors for people having more severe disease. And we see that those particular risk factors are more prevalent in communities of color. So those are the two things that would contribute to why Black women might be particularly more at risk. Next slide. So this slide actually just really talks about, is meant to point out the disparities that we see in COVID-19. So despite the percentages that folks make up in the community, in New Jersey, I believe that it's like 13 to 15% African-American, but we can see based on the state's population, which is the top bar on the left-hand side, so about 15% of the state population. But then when we look at the number of cases, we're comprising almost 20% of the cases. When we look at hospitalizations, again, we are 20% of hospitalizations, and it looks like, again, the same for deaths. So we are comprising more than our percentage in cases, hospitalizations, and deaths. And that's why that's what contributes to this disparity. Next slide. So what are the tools that we have? Okay, we've been talking for almost a year about hand washing, avoiding contact, avoiding crowds, not touching our face, cleaning surfaces, avoiding non-essential travel, calling ahead before going to the hospital or to the clinic, isolating yourself if you're sick, working from home when that's possible, and wearing a mask, and also coughing and sneezing into your elbow. Now we also have testing as a tool, because we know, particularly for younger people, but for people of any age, that people can be what we call asymptomatic carriers. They can be carrying COVID-19, they can be exposed and they can be carrying COVID-19 and not have any symptoms. And so if we know that someone is testing positive for COVID-19, that can be a tool, because we can isolate that person to prevent them from spreading it to other people. And now we have a vaccination. And so we have yet another tool. Doesn't mean that we're not going to do the other things, but we keep adding on different tools. Next slide. So what is a vaccine and how does it work? And again, I think we take for granted, we think everybody just understands all of this. And I spend a fair amount of time talking to patients, because many of my patients are pregnant and they haven't had a vaccine for a long time. You know, when a lot of times when we think about vaccines, we think about children, but in pregnancy, there are 2 vaccines, now 3 vaccines that are recommended. So we recommend all pregnant women get the flu vaccine. We also recommend all pregnant women getting Tdap, or the vaccine for whooping cough. And now we're also saying pregnant women are able to get the COVID vaccine. But what are vaccines? Vaccines prevent diseases that can be dangerous or deadly, okay? They help work with your body's natural defenses to develop a protection from a disease. And a vaccine helps your immune system produce antibodies. And so just like it would if you were exposed to the disease, okay? After getting vaccinated, you would have protection from that disease without having to get the disease first. And so that's what makes vaccines so powerful. Okay, unlike most medicines which are used to treat or cure a disease, vaccines are used to prevent them. And so yes, your body, you can develop a natural immunity from COVID if you get COVID. We still don't know how long that immunity is going to last. But the problem is, if you get COVID, you also could get severe disease and die. And so it seems to me that it might be better to get the vaccine and get immunity from the vaccine rather than getting immunity from the disease when there is a risk of death. There's no risk of death from getting the COVID vaccine. Next slide. So what are the benefits of getting the COVID vaccine? So the COVID vaccine has really been shown, all 3 of the available vaccines have been shown that they can help us from getting sick, particularly severe illness that would require hospitalization and death, okay? All of the COVID vaccines that are available in the United States have shown to be very effective. Wearing masks and social distancing will help us from the chance of getting the virus and spreading it to others. And the combination of getting vaccinated and continuing to follow wearing masks and social distancing until enough of us are vaccinated is going to still be very important, okay? And I can see that someone typed in I didn't communicate with anybody before this conference, but somebody typed in to the chat box about there's been some reports of people dying after the vaccine? Thank you so much for that question, because it's really important. And a lot of people have been asking that question. And so, you know, I think there's a slide a little bit later on, but I'll just touch on it for now. There have been people who have died after getting the vaccine, but none of the people who have died after getting the vaccine have been linked. They haven't died from COVID. They've died from a heart attack. They've died from cardiovascular disease. They've died from car accidents. And so, unfortunately, yes, people have died after the COVID vaccine. And of course, any death is a tragedy. But these deaths, these incidents have been investigated, and they're not dying from COVID. And people are gonna die from a heart attack. There are plenty of people who have died from a heart attack during this pandemic that didn't get the COVID vaccine. So I think that's an important question. Next slide. So what vaccines are available? We have 3 vaccines that have received what is called an emergency use authorization. And you'll hear people say EUA from the Food and Drug Administration, from the companies Pfizer, Moderna, and Janssen, which is also known as Johnson & Johnson. All 3 approved COVID vaccines are safe and highly effective against serious illness, hospitalization, and death. The Pfizer and the Moderna vaccine require 2 doses. So the Pfizer vaccine has 2 doses that are given at least 3 weeks apart, and the Moderna vaccine has 2 doses that are given at least 4 weeks apart. And people have to get both doses in order to be fully immunized, immunized against COVID. And the Johnson & Johnson vaccine, which is the latest to have received the emergency use authorization, is only 1 dose. Next slide. So how do we know if the vaccine is safe? I get this question all the time. And again, it's a great question. And I really want to emphasize that I believe that questions are important, and we teach our children. I still have 2 school-age children, and I'm telling them all the time, there's no such thing as a silly question. You ask questions to get information, to educate yourself, and to make the best decision for yourself. If you don't ask the question, then you are operating without having all the information. Okay, so I want people to ask as many questions, and I always end my encounters with patients by making sure that they don't have any questions. And yes, in the chat box, it was stated that the J&J is not available now. So that's true. Just as of yesterday, the FDA, like I said, at the beginning of the conversation, put a pause on J&J because they're looking into the fact that 6 people have had blood clots. 6 women between the ages of 18 and 48 have gotten blood clots. We don't know if they had those blood clots before the vaccine. We don't know if they got the blood clots after the vaccine. So we're gonna do some investigation. So for now, they've asked us not to administer J&J vaccine, but 7 million people have gotten the vaccine already. And so we're still gonna talk about it, but for the very moment, this very moment, it is on pause, okay? So vaccines have to go through more testing than any other pharmaceuticals. Small groups of people typically receive the trial vaccine, and then the vaccine is given to specific groups of people, and we try to include people of all different ages, all different races, and all different physical health, because at the end, we want to be able to say that it's effective. And we can't say it's effective if we haven't tested it in all these different people. So all of the vaccines that are available have been tested in tens of thousands of people and tested for effectiveness and safety before the EUA was given. Both Pfizer and Moderna were tested in over 30,000 people before that EUA was issued. Next slide. So how do we know if the vaccines are safe? Again, the CDC, Centers for Disease Control, has an advisory committee on immunization practices. They look at the data to see if the vaccine is safe and works. They give advice to the US Food and Drug Administration. And then the FDA also looks at the data and the advice from these advisory committees and decides whether to approve the vaccine. And I would also say that in this setting of COVID, because a lot of different professional organizations were concerned about the data, different groups like the American Medical Association and even an organization that I'm a part of, the National Medical Association, which is a group of physicians of color, national organization of physicians of color, asked to see the data of these vaccine trials before they, as an organization, would agree that the vaccines were safe and effective. The vaccine is only approved after all these steps are done and various teams of reviewers are sure that it works and it's safe. Next slide. So again, question that people ask me all the time, how is it safe when it happened so quickly? Fair enough question, very fair question. And so it's interesting to note, you know, what we will do with money, okay? I mean, that's really what it comes down to. What the power of money, okay? The timeline was sped up, but there were never any corners cut on safety, okay? So we already had some helpful information about coronaviruses. It wasn't that coronavirus itself was new. There was already known to be a family of coronaviruses, this particular coronavirus. A lot of people, because people were dying, a lot of people were willing to participate in the clinical trials. So we didn't have to spend nearly as much time and effort trying to find volunteers. The US and other governments and other pharmaceutical companies invested a lot of money to support the vaccine companies with their work. Okay, and that was key. And some of that money was diverted from HIV research that had been done. But if we had to start from scratch of finding money to get this vaccine off the ground, it may have taken a lot longer. And then manufacturing happened at the same time as the safety studies, so that as soon as they knew that as soon as they presented that data, and believe me, the companies weren't going to present this data. As soon as the companies presented the data, they were also manufacturing the vaccine at the same time. And so what that allowed for, as soon as the emergency use authorization was issued, that means the vaccines could go out right away. So, you know, it's a lot of financial risk for the pharmaceutical companies. And I don't work for the pharmaceutical companies. I don't have any stock in them. You know, I'm not saying this because I feel sorry for them, but I'm just saying there is some financial risk for them to make this vaccine if their data was going to be questionable. So they knew their data had to be tight because there was a lot of eyes on them to make sure that this vaccine was safe and effective. And if they weren't going to get the authorization, you know, why would they produce it? Okay, next slide. So this just shows you in a timeline, the traditional timeline. The traditional timeline, things go step by step: research, initial development, testing, then they wait for approvals, and then they start the manufacturing development, and then they deliver. In the case of COVID-19, that research A lot of that research had already been done. Some of you may be aware that the technology, particularly for the mRNA vaccines, was developed by a Black woman, Dr. Corbett. And so the technology was there. It was waiting for an appropriate pathogen, okay? The initial development, and then the testing started to occur. And once they started to get some positive results from the testing, the manufacturing and developing started. And then they still had to wait for the approvals. But once the approvals were given, they didn't now have to spend extra time waiting for the manufacturing and development to occur. Next slide. Can I get COVID-19 from the COVID-19 vaccines? No, the vaccine does not contain live virus, and that causes COVID-19. So you cannot catch COVID-19 from the vaccine. Okay, and I would just say that it's not, there's no such thing as a silly question. There are some vaccines. If anybody has heard of the polio vaccine, we have both live polio vaccines and we have inactive polio vaccines. So in the very beginning, this is how vaccines were created. We took a little bit of that live virus, that live pathogen, and a small amount of immunity was developed. But this is not the case with the COVID-19 vaccines. They do not contain live virus, and so you cannot get COVID. Now, if you happen to get the vaccine and you think, oh, I'm cool, I got vaccinated, I can go out there and go to the supermarket and hang out and do whatever, it doesn't mean you cannot, your immunity doesn't develop as soon as the shot is in the arm. So you can get COVID-19, you can still be exposed to it, even once you've gotten vaccinated. But there's no live vaccine. There's no live virus in the COVID vaccine. Next slide. Does the COVID-19 vaccine have any side effects? Absolutely, okay? Fortunately, the serious side effects from the vaccine are rare, okay? The most common side effects that we see are minor and include tiredness, headache, pain at the injection site, muscle or joint pain, and some people also have had chills, nausea, vomiting, or fever. I wish that we could predict who was going to get what side effect, but we can't. And I have known people to have all ranges of these side effects. Some people have nothing at all, and some people I have known to have both nausea, all of the side effects listed, okay? And there's also no timeline as to when these side effects can occur. Usually we are saying that they occur within the first 72 hours of getting the vaccine, right? Because your body, you're given the vaccine, and the vaccine is teaching your body how to develop immunity against that spike protein. So some people have some of the minor side effects, like the pain at the injection site, can occur right away. But it is true that people can get it a few days later. Okay. But I do want to emphasize again that when a person has side effects, I don't say it in a mean way, but I mean it to be true. That's good. That means that your body is building the protection that it needs. Okay. Most people are able to do their normal daily activities, and these minor side effects will go away in a few days. Next slide. I see there's some questions in the chat, and I will address them. I would like to have a baby one day. Is it safe for me to get the COVID vaccine now? Yes, people who are trying to become pregnant now or who plan to get pregnant in the future can receive the COVID vaccine when it's their turn, okay? There are statements from the American Society of Reproductive Medicine and other professional organizations. And so there is again, the vaccines do not enter your DNA. They do not cause any problems with fertility. And based on what we know right now, remember what we said is that the vaccines were tested on people of different ages, different races, and with different medical problems. Unfortunately, it was not tested on pregnant women, which is why we can't say, well, in clinical trials, women who got the COVID vaccine, we can't say that because pregnant women, unfortunately, were excluded. There were some women who got pregnant. They weren't pregnant when they initially got the COVID vaccine during the initial trial, but they became pregnant. And so we have been following those women to see the effects. I think one of the first women has already given birth and has shown that antibodies against COVID-19 were passed through to her baby and into her breast milk, which is great news, which we knew all along. So based on what we know right now, we believe that the vaccines are safe for someone trying to become pregnant in the short term and in the long term. And hopefully she's going to talk to us also about some of the trials that are ongoing for pregnant women who are choosing to get the COVID vaccine. Next slide. Should someone who's pregnant or breastfeeding get a COVID vaccine? So again, it's a personal choice for people who are pregnant or breastfeeding, and we're recommending that folks have a discussion with their healthcare provider. And when people come to me to ask me that question and I'm their healthcare provider, I talk to them about the things that I know about them, what their risks are, and why I think they should consider it, or things, you know, their individual circumstances. The American College of Obstetrics and Gynecology recommends that COVID-19 vaccines be offered to pregnant women and breastfeeding individuals when they are available. We don't have data about the COVID-19 vaccines, as I said, because pregnant and breastfeeding women were excluded from the studies, unfortunately. But we do know that getting sick with COVID-19 during pregnancy can increase the risk of severe illness and might increase the risk of outcomes like preterm delivery. Next slide. Are COVID-19 vaccines safe for children? The Pfizer vaccine is authorized for people who are 16 years and older. The Moderna vaccine and the Johnson & Johnson, when it resumes, are going to be authorized for people who are 18 and older. Right now, there are studies for younger children and adolescents, but right now, they're not recommended to get the vaccine. Next slide. Will the COVID-19 vaccine change my DNA? No, the COVID vaccine does not change or interact. It doesn't even enter your DNA in any way. It teaches your immune system how to develop an antibody against the spike protein. And so in order to do its job, it doesn't even go into the nucleus of the cell. It doesn't go into the DNA of our cells. So it never interacts with our DNA in any way. Next slide. So some people say, I'm concerned because I've heard that some people died after getting the vaccine. And so, you know, so far, as of when I put these numbers together, which was over the weekend, 31.2 million people. We've had 31.2 million COVID cases in the United States. And we've had 561,000 people who have died, deaths after COVID. And I put that plus there because the plus is for the people, the numbers that we have, that 561,000 represents people who died from COVID. It doesn't represent people who were afraid to come to the hospital and died at home from their heart attack. It doesn't represent people who were afraid to come to the hospital and died at home from a stroke. In New Jersey, we have had 839,000 cases of COVID. and 22,000, over 22,000 deaths. Again, not including people who didn't make it to the hospital in time for other complications. We have administered in the United States 183 million vaccines. And we have, anytime someone is hospitalized or anytime someone dies after getting the vaccination, it must be reported. That's part of the reporting system for the vaccine. So there was an organization, that organization, VAERS, that is required where these hospitalizations and deaths are reported to, reported that 966 deaths. So this was fact-checked by Newsweek. Newsweek did their own independent investigation to check and see. And what they found is that this was true. But these, again, were not deaths from COVID. These were people who got the vaccine 2 weeks later, 4 weeks later, they were hospitalized, they died from heart attacks, from strokes, from heart failure, from a car accident. So in New Jersey, we've administered at least 3 million, over almost 3.5 million vaccines, at least one dose, and over 2 million people fully vaccinated if they were getting 2 doses. So that's only 24.6% of New Jersey's population. 9 million people in New Jersey, over 9 million people. Okay. So next slide. So take-home points: can pregnant women get a COVID vaccination? C, yes. However, whatever language you want to use, the answer is yes. Next slide. And I'm open to any questions. So I think what we should do is just, I know Assistant Commissioner Lisa had to take off. So Chi, why don't you go into your presentation? I'll look at some of the questions in the chat, and then Marie can present, and then we can go back to the questions.
Okay, sounds good.
I'll turn it over to you, Chi.
All right. Okay, great. All right, I hope everyone's doing well. Happy Black Maternal Health Week to everybody. It's definitely a privilege to be presenting during a crucial time such as this. So my name is Chinamenma Amanu, and I am a doctoral public health student working with the Department of Health. I work closely with Kathy. Kathy is the lead on our project, but I work with the infant follow-up piece. And what I do is, again, I work with the infant follow-up piece, and I also work with the maternal outcomes for COVID positive moms, but that's more of Kathy's lane. So I work exclusively almost with the infant follow-up piece. So we're also in partnership with the CDC as far as collecting data on COVID positive moms and infants and just the data surrounding that. We're working with 21 other jurisdictions. And what we do is we actually are involved on a monthly call. So once a month we get together and we just discuss about what exactly is happening around the United States, because these are jurisdictions from other states. You can see on the slide in green who we also do this project with. So we get on the call and we discuss about what's going on, how they're tackling getting their data from different PEDS offices or OB offices as well. So the next slide, please. So what we know now about COVID-19 and pregnancy is that mother to baby is actually very rare, but when it occurs, the baby illness is very mild. So as far as like outside of the maternal child piece, we know about horizontal transmission, which is COVID being carried through respiratory droplets. And this is why we wear our masks, so that when we're talking, our spit or however is not getting on other people while we're talking, in closed spaces as well. So we're looking specifically at mother to baby transmission. We also know that most pregnancies do not have significant maternal and infant adverse outcomes. But also on the bad side, we know that pregnant women are at a higher risk for getting admitted to ICUs or being put on a vent or even death, as Dr. Campbell said earlier, as compared to other non-pregnant women of the same reproductive age. And then we also know that, again, as was said earlier, preterm delivery is more likely as compared to prior national averages. Now, these can also be complicated by instances such as the weathering effect, which is the effect of societal pressures on women of color, since we're roping it back to women of color during this week, as we're looking at Black maternal health. So other confounding factors can account for these preterm deliveries, but this is what we know as far as COVID is concerned. Next slide, please. So what we're doing now is we are looking at cases at the Department of Health. We are doing this through various means. So on our CDRSS, which is the Communicable Disease Reporting System, we have a question that asks, is patient pregnant during investigation? This is important because this lets us know, hey, we need to look closely at this case because the mom is pregnant and they could possibly have a COVID diagnosis. So this is through our contact tracers or by a testing facility. They ask the mom, are you pregnant? And then they mark it down and go from there. Then also we get our data from whenever a mom steps into an ER or any type of medical facility, and we have our billing data. So the ICD-10 codes, we look at that as well. We also match up COVID cases to birth and fetal death files. And then we get our data actually directly from the hospitals themselves. So we do this through our infant follow-up form, or for the maternal side, we also have a maternal form. Next slide. Okay. So we also look at birth and fetal death certificates. We match them again with the COVID diagnoses. We look at birth weight. We already asked this anyway, but again, we're looking at this specifically for COVID-19 and its effects on moms and their babies. And you can see there that we also ask about any comorbidities for the mom, any birth defects, gestational aids at delivery. We also have our nurse abstractors that take data from the medical records. And we have Joy, that's the one that's on point for the maternal case abstraction. We look at whether the baby roomed in with the mom. We look at breastfeeding. Did the mom breastfeed or did she use formula? We also look at the infant testing status. Was the baby also tested? And then specifically for my part of the project, we look at, first of all, we contact hospitals and we ask for their medical records for the babies. And we see their 2-month and 6-month well child visits. We look at how they're growing, again, birth weight, as we said before. We also look at any additional testing that was mandated or done. We also look at whether the baby had referrals, any abnormality with looking at all of the systems of the babies. So we look at all of that specifically. I believe there's some animations on this, so I think you can do 3 clicks, please. Yes, thank you. Okay, so when we first looked at the start of this pandemic, which was last year already, we can see that the state totals for the first positive test date of pregnancy cases were pretty high up there, roughly 1% of total cases. In the summer, you can see in the middle there that we had a little bit of a decrease as far as the reported cases per day. And then as we're approaching, as of maybe February, March of this year, we can see that the totals have gone up, mostly because we found tools to accurately, or as close to accurately as possible, report these cases. And the totals will most likely go up as we continue to ascertain cases. Next slide, please. Okay, so you can see also that this is the COVID case comparison to births of 2019. So you can see already that for Black non-Hispanic women, the totals are about the same. So you can see that whether the woman had a COVID positive pregnancy or diagnosis or is pregnant, they're pretty much the same. And you can see that between white non-Hispanic women and Hispanic women, those totals vary. But again, for Black non-Hispanic women, they stay pretty much the same. And you can see that the bulk, almost half of COVID pregnancy cases are attributed to Latina women. And this is as of March 8th, 2021. Okay, so we would like to know where are the most pregnant cases per pregnancy in New Jersey. Okay, so you can see here that on the left side, we have our chart, and we see that Bergen County has the most cases, but they're also the most populous in New Jersey. And then on the right side, you can see that Passaic County is the darkest because it has the most cases when using the rate of per 100,000 people. So Bergen County has the most amount of people and most amount of cases, but when we put it on a rate, you can see that Passaic County actually has the most cases. And you can see also, because of the numbers, that Cape May has the least number of cases, but they also have the least amount of people in general. So we can see here that where people are in New Jersey doesn't necessarily equate to where the pregnant moms are. You can see here that Ocean County has the highest fertility rates. And you can see also that fertility rates vary across the county, and they depend on the number of childbearing age women. So if a place doesn't have that many women that are between, say, 18 to 40 years of age, you're not going to get that high of a fertility rate. But in Ocean County, we see that that category of people is the most populous. And you can see still that, you can see still that Ocean County has the highest amount of cases, but still the amount of cases are still in Passaic County as well. So the next slide, please. Okay, that was to this slide. So the following slide, please. Okay, so we have a list of maternal outcomes. This is very crude, by the way, and this is specific to New Jersey. So we can see that, as Dr. Campbell said earlier, generally most babies and moms are fine. So that's great news. We could see that those that had no major complication, the live birth rate is high, stillbirth and miscarriage are low. ICU admits about 2.5%, we can see that they had live births, and then again, a low stillbirth and miscarriage rate as well. And then the maternal death rate, which we do collect data on, is relatively low as well. So while we see that these numbers look kind of good, we still definitely encourage moms to get vaccinated during pregnancy. The next slide. Okay, so if you have any questions, you can contact Kathy or myself. But definitely with this, we're trying to get the message out there that we would rather weigh the risks. Like, we heard about Johnson & Johnson, yes, but it's a small risk compared to having a fatal complication from COVID itself. So we want our moms and babies to be alive. That's the bottom line here. So thank you so much for letting me present. And again, any questions, my email is there. Kathy and Kathy's email and cell are also there. Thank you so much.
Thank you, Chi. Let me chime in. I'm Myra Ramirez. There was a snafu with the registration, so you may see Myra Ramirez popped up throughout the screenshots. And thank you, Dr. Campbell. There are some questions on the chat that we wanted to get to. But before we get to those questions, I want to pass the baton over to Marie Kinsella. And she's going to speak about, her perspective as a doula and, in terms of her work in Northern New Jersey as a director of community programs. So Marie, I pass it on to you.
Well, thank you, and I appreciate the invitation. First of all, I want to say I'm very new to the doula world. I was very energized and intrigued by the doula work and advocacy that was going on in the state of New Jersey. And so I decided that this was something that I wanted to do. And I guess I want to start by saying I was a doula before I knew what a doula was. And what I mean by that is I was supporting my daughters through their pregnancy. I was supporting my granddaughters through their pregnancy. I was at those births. I was trying to make sure that they had everything they needed to ensure a healthy pregnancy. And so, just being in this maternal child health world, and specifically looking at infant and maternal death in the African-American community, particularly over the last 4 years, made me really start to think about, as I move forward through this career, what do I want to do afterwards? And for me, a doula just seemed to be a natural fit. So what is a doula? A doula is somebody who can provide emotional support, really help with what we call comfort measures, give guidance, really help advocate, for the people that we are supporting, the birthing people that we're supporting. And I'm just really excited because it seems like in the last 2 years, there's been a lot of momentum around, having doula support, particularly in New Jersey. And I just guess I want to say the doulas can't do it alone. I mean, they definitely, have the wherewithal, and I've been in the company of some wonderful women, and, they have the drive and the fight, but also legislation is needed. And I'm pleased to say that I've been seeing it going in that direction, in the state of New Jersey. I've been looking at infant death and maternal death among Black women for the last 30 years. And I agree with Lisa when she says that, there's a lot of light on this now. We saw those headlines. Those are the things that are being pushed into the news. And I think because of that, now we're trying to figure out the strategies that are going to help ensure a healthier pregnancy. And I would say a doula is one of those. I am a full spectrum doula, which means during the pregnancy, I'm there to support. And really, for me, it's about, with the wonderful resources we have in New Jersey, currently, let me just say this, I'm so happy about this. I have 2 granddaughters who are currently pregnant. And so it's been very interesting to hear what they're feeling. And although I've always supported, my female members with this additional training that I received as a doula, it's really helped me open up other conversations with them. And I have the one granddaughter, because of COVID, she's terrified. She's like, I don't know, Grandma, because she didn't plan the pregnancy, but she is the pregnancy. And she said, like, what am I going to do? I'm going to be afraid to go into the hospitals. And, just hearing some of the wonderful information through this last year, particularly Dr. Campbell, you've been extremely helpful with a lot of the information that you've provided to us around the safety in terms of COVID and delivering at the hospital. But she was really, really nervous about that. And again, those are some of the things, because the doulas are trying to take in as much information as they can, particularly in the times of COVID, to really reassure, who we're working with, that birth is a natural thing. And that even during this time, people, as Dr. Campbell said, people are having babies. And so just hearing her say that let me know that she needed some sort of emotional support, yes, I can calm her nerves and everything, but I really wanted her to look toward talking to a professional in that area. So again, you know, as a doula, you can determine whether, you know, that person needs just a little bit more. And if they're trusting of you, they're more likely to connect with that resource. Now, for the other granddaughter, and because I really want to talk about the referral process and what we can do. Yes, I'm going to be there to support both of them, but for my other granddaughter, this is her first baby. And I thought, wow, I started talking to her about nurse family partnership. And, you know, what did she think about that? And really just kind of exploring things with her. Yes, I can provide her information and education, but it would be nice for her to have that additional support. And so she was really, I was very delighted that she said, yeah, I think I do want that, but Grandma, just make sure you stay close. And so I am going to certainly do that. You know, in terms of other referrals, you know, I think that, you know, in addition to the support we can provide, when we look at all the other things and all the other opportunities we have in New Jersey that can really ensure a safer pregnancy, because that's what it's about safety. We have centering sites, and centering pregnancy is an ideal way, and we see that it definitely has some positive outcomes as it relates to Black women. There were studies done, big studies done in the South, particularly in South Carolina, around the positive birth outcomes in Black women for centering. So knowing all of these things, we can really support, you know, the birthing people that we're working with. You know, again, it's really about talking about nutrition and really, you know, trying to figure out, you know, how do you want to feed your baby? You know, of course, you know, I'm going to advocate for breastfeeding, but it's important to know what the mom feels. And I think, you know, those are some of the things that we do. And if a referral is needed for WIC, then they're connected with that. You know, there are so many ways that we can really support our women. So referrals are definitely needed. We'll assess what they need. And just provide those, you know, them with those referrals. I didn't have a formal presentation, but as I was listening to and looking at Dr. Campbell and there are some things, there is a PowerPoint that I want to bring up that's short. And Sarah, I did send you a message to see if I would be able to do that, because I do want to talk a little bit about comfort measures. And I think it's really important that we let women know that there are ways that they can get through a pregnancy and get through safely. You know, my granddaughter was very concerned. She wanted to have a VBAC, and they told her, no, that's not possible because she had 2 C-sections. And so we're exploring that a little bit more. I've been talking with her OB, and we're just trying to figure out what is going to be the safest route for her. So I can share my screen. Is that what you're saying? Okay, so share screen. And I will bring this up. And so I just want everyone to see, let me do this. This is really short. And I just put some comfort measures, and you can see one of the best ways to comfort someone is that hug. And if they allow you to be that personal with them, that's great. Let me go to the next one. So, you know, of course, there's general anesthesia, you know, and of course it has its pros and cons. There is non-medical pain relief. And these are some of the things that we're trained on as doulas, but just know this, we are not giving medical advice. I want to say that first and foremost. Our job is to be there to support the laboring person during labor, but we are not going to interfere with the medical piece of that. You know, that's not my job. I do not have medical training. And one of the things that I really like in New Jersey, I think that more and more obstetricians are becoming open to having, you know, doulas be a part of the birthing team. You know, so music, you want to find out what sort of music they like, you know, and you want to play something nice and soft, particularly if they're in the delivery room and not, they're having a birth at a hospital. You have to know, what's happening within that hospital, and is music allowed, and that sort of thing. You can always do the massages, guided meditations. One of the things that I've been working on is building my skill set around providing meditation, whether it's a visual or, auditory, something that I can support, the laboring person and help them get through that. Focused breathing. These are some of the techniques that I've been using. And just, and then there's types of pain medication during labor. There's the analgesic, which is injections, IVs, and there's pros and cons. It depends on what is happening with that birth. There's the epidural. And again, I just want to bring these things up so that, there are pros and cons to everything. And again, this is a decision, that's made, in conjunction with an OB, but also you want to see what the birthing person's birth plan is. And then let's see what, let me go to the next one.
Marie, I wanted to chime in for a quick minute. Are doulas currently allowed to be in the hospitals during the delivery? What is the current status?
Okay, so Dr. Campbell, would you mind answering that? Because I'm excited.
Yes, absolutely. I was waiting. So in the beginning of COVID, of course, everything was on lockdown, but we have a governor's order, okay, that not only allows patients to have, for laboring patients, so this is everywhere in the state of New Jersey, okay, patients are allowed to have at least one visitor and a doula, and the doula is not to be considered the patient's visitor. So it's still a bit of a limitation because most of the hospitals that I have worked at generally allow 2 people. But to be quite honest with you, when they allowed 2 people, they were allowing the doula was counting as 1 person. So it's really, kind of the same. I would love to see a situation where we allowed, 2 people plus the doula. But, the current situation, and there are a lot of reasons that, things to consider, and each facility, has different resources. But the most important thing is to keep the patient centered in all this and what the patient's need is. And I just wanted to chime in with Marie in terms of these comfort measures. And I so appreciate you presenting this. And I hope I know we're friends for a while, and so I'm gonna lean on you to present, maybe to some of my medical students and residents, because most of the time, the reason why residents and medical students will go to the medications is because we don't have the skills to really suggest anything else. And I have been working with some doulas over my career, and so I've learned about some of the non-medical pain relief, but you can't really offer people what you don't know. And so,
Yeah, that's exactly right. And Dr. Campbell, yes, we've been together for a very long time, and actually I have my granddaughter, because it's just my 2 granddaughters that I'm really supporting, because, I do have a full-time job and I really want to get the experience that I need. So it's like, don't if they have back pain, one has sciatica, and, of course I'm telling, don't lift heavy things. Sleep on the left side with that pillow, and as her belly starts to get bigger, maybe a belly support would be necessary. And then just a heating pad and for her back. And Dr. Campbell brought up a great point. I think one of the other things that I'm doing is involving the family, because the family is going to be a support as well. So to be able to provide them, those family members, with suggestions and, the way that they can help calm and, I can help them stay calm and secure while the process is going on, while that labor may be a little longer than they thought it would be, because some people are just under the impression that, it's, you feel the pain, you go to the hospital and you have the baby. That's not so. And
it's
so
like
these are just some
reality TV, right?
Yes, these are just some of the more typical things that, might happen, leg cramps, and so again, providing that birthing person with these comfort measures are really going to make for just great outcomes. And again, just knowing that there's fatigue and sleep problems that may occur, during pregnancy. I'm trying to figure out why so again, with my granddaughter, she was having some challenges sleeping. So I was asked, like, what does that look like? How are you sleeping? And again, just knowing to go to bed, same time, wake up, and, because she's been doing a lot of sleeping. And, have the partner, family, or friends, or me help around the house, run errands. And this is because, as I said, I'm a full spectrum. So I know that after they have the babies, grandma's going to be there to do certain things and support them, and actually help their husbands learn that they need to be very vested, and they can be very vested in this particular piece. And then again, the warm shower.
I want to chime in and ask an important question. People may be wondering a couple of things. How do you become a doula if you're interested? And two, does the standard health insurance pay for doula? How does the mechanic work in terms of insurance?
Great, Myra, great questions. Again, New Jersey's at the forefront. We have, and Dr. Campbell, you might be able to speak to this a little better than I, but they are now allowing women to get doulas if they have Medicaid. You can charge your doula's cost to Medicaid. However, the reimbursement is very low. And again, this is where legislation comes in, because doulas can do so much to a certain point. And once we get the legislation pieces in, things will be better. And again, we have a very pro-doula state. There's been a lot of where they have at the assembly, and people are coming in and speaking. So yeah, and the doula, how do you become a doula? There are several. My suggestion would be for anyone who's interested, really take a look at who's offering the services, see it, make sure that they're somebody who is recognized as a great support for that. I actually went through Ancient Song Doula Services, which is out of Brooklyn, but I did a lot of research before I selected them. I really went through a lot of things and really felt that that particular training, that organization would be the best fit for me. And so, yeah, and I mean, if you just have the passion there for me, because I feel like, hey, when I retire, am I really going to retire? What do I want to do? And so, and so we know hemorrhoids happen during pregnancy. And these are all the, the things that I talk to. My granddaughter right now is experiencing morning sickness. She feels like it's a lot more than normal, but we're helping her get through it, and just helping her know that that's a part of the process. And I just wanted to share that with you. And in closing, because we have a few minutes, one of the things that I did do was I put together, when I think about a doula, what does that look like? So I put together a bit of an art project, and it's really short. And I just want to show this to you guys. Let me just.
Marie, if you're okay, I posted your email in the chat.
Oh, that's fine. That is fine.
And by the way, if we don't have enough time to answer everyone's questions, we will follow up. We're recording this session, so hopefully everyone's okay with it. I apologize for not mentioning that earlier, but we will go through the questions. Go ahead, Marie.
So I do want to share this. Let me bring up, where is my art project?
Well, in the meantime, I can start answering some of the questions.
Oh, great, Doctor.
Marie is looking up, getting the art project.
Yes, let me help you out and go to the questions. There was one follow-up question earlier. Is there any medical linkage per se that can exist between the COVID vaccine and heart attacks?
Yeah, so yeah, I did see that question, and no, there is none. I think, again, we're looking at this, even people who have survived COVID, and there's some report of people who have survived COVID and have gotten blood clots. So, but you don't get per se a heart attack just from having high blood pressure once, or you don't get a heart attack from having blood clots once. You know, usually having a heart attack has to do with reduced oxygen to the heart, which is a result of something that's called atherosclerosis, which is blockage of the blood vessels that lead to the heart. So as far as I know, there have not been any direct links from COVID to people having heart attacks, but unfortunately, you know, because of our diets, eating so many processed foods, not, you know, exercising as much as I would like to, you know, I mean, people do have heart attacks. So, I mean, but I think, again, just like this whole J&J pause, where it's always a good idea to look into it and to ask questions. I know there was also a question about when should women get the Tdap vaccine?
Yes.
Which is a vaccine for the whooping cough. So that's recommended in pregnancy. It can be given at any time in the pregnancy, but most people are commonly giving it in the second trimester after 24 weeks. And someone also asked about the flu vaccine.
Yes.
And so flu vaccine is typically given during the flu season, which typically runs from October to March. So right now, because it's April, we're not giving the flu vaccine anymore. We'll start to prepare for the 2021-2022 flu season. One of the things that happened last year is we really made an extra effort of push for people to get the flu vaccine before COVID vaccines were out. And, you know, that was successful because we saw far less people die from the flu in this past year because more people got the flu vaccine. And someone asked a very important question about, because there is one thing about getting the COVID vaccine. If you get the COVID vaccine, you cannot get any other vaccines within 2 weeks. So that's important to know. You can't get any other vaccines within 2 weeks. Okay, it looks like Marie has her presentation.
Yeah, and I just wanted to say thoughts about birth. And so you see, what you see here is you see a family, you see the baby, you see mom and dad. And so that's how, when we start to think about birth, that's how we need to look at it, you know. And again, you know, just angels with joy and love. You know, when I think about, you know, as mom is carrying that baby and, you know, that she has the angels around her, I just feel like, you know, sometimes we have to draw on our ancestors, at least for me, and just kind of bring that in to, and talk with that birthing person to see, you know, what they believe and how they feel. You know, and always remind them that babies are angels. You know, sometimes, you know, you'll hear a mommy say, oh, this baby's just doing some things to me that I don't like. And, you know, the baby, I had one young lady say, this baby is kicking me on purpose, you know, and I had to remind her, you know, that I don't know that that's true, but we did talk through that. The most important thing that I want to say is bring fathers into the fold. There is this misconception that our Black dads are not interested. And that is so untrue. And I think that if we, as we're working with that birthing person, if there's a male partner, let's make sure we bring them into the fold. You can see one dad here, he's braiding the hair of his baby. I just think that's important. Always remember that we elders are here. We're seasoned, we've been through it, and we can be supportive. And then finally, this is my final message, that pregnant women are beautiful. And so, I mean, I'm just so delighted that I was able to really, you know, get an experience of going through the training and now really working toward becoming that experienced doula, that I'm going to be doing that for as long as I'm here and as long as I'm able, you know, and I just think it's important. Doulas are important, and thank goodness New Jersey understands that, and we will be able to really, hopefully, with all the legislative support with doctors like Dr. Campbell and Dr. Brew, who are open to new ideas and thoughts and advocates, we're going to make some change. I believe that we can see some differences in the birth outcomes that we're currently seeing. So I really thank you all for allowing me to be a part of this.
Well, thank
We
you.
have to
Marie.
make some change. Yeah, we have to
Yes.
make some change because things have been the same for far too long. I just want to get to one last question,
Sure.
which was about, can you get COVID again if you already had it? And so you can get, there are some reports of people getting COVID twice. And so, and it is true that you can also get COVID even if you've gotten the vaccine. And so again, it goes back to people say, well, I got the vaccine. Why do I still have to wear a mask? Why do I still have to social distance? And there is some guidance from the CDC about things that you can do. So people who you already live in the house with, you can obviously be in your house without a mask. But then if you're going to places where there are people you don't know, people that you haven't been in close contact, again, then you want to take more precautions. And we're still, even once people are vaccinated, until we reach that, you know, what is called herd immunity, that percentage, 70 to 80% vaccination rate across the state and across the country, we're still recommending to avoid medium to large gatherings. So, you know, I know that there are a lot of questions, and I know that we don't have all the answers. We have to continually ask questions, and asking questions doesn't mean that you're challenging. And actually, I kind of think it's okay to challenge and ask authority questions. I'm actually kind of okay with that.
Me too.
But I think that, you know, we have to ask questions so that we can make informed decisions with information that we have. And so I thank you so much for inviting me.
Thank you.
To present, and thank you to the other presenters as well.
Yes.
Doulas are very important, and all people are very important to the conversation because it takes a village.
Yes.
With all that we do, it takes a village.
Absolutely.
And so
Well,
I look forward to working with everybody. Thank
Well,
you,
thank you. Thank you, Dr. Campbell. Thank you, Marie. Thank you, Chi. And thank you to Sarah Ashard, who's part of our team, who was helping with the mechanics. And again, the session is recorded, so we will make it available. And we will try to answer all the questions and share it with everyone who registered. Thank you, everyone, for attending. Have a great evening. Be safe.
Thank you.
Take care.
Thank you.